topic osteoporosis. Previous two videos ನೋಡಿಲ್ಲ ಅಂದರೆ menstrual cycle and menopause Dr. D YouTube ಚಾನಲಲ್ಲಿ ನೋಡ್ಬೋದು. ಸೊ ಟುಡೇಸ್ ಟಾಪಿಕ್ ಈಸ್ ಆಸ್ಟಿಯೋಪೋರೋಸಿಸ್. ಆಸ್ಟಿಯೋ ಅಂದರೆ ಬೋನ್, ಪೋರೋಸಿಸ್ ಅಂದರೆ ಪೋರಸ್. ಬೋನ್ ಬಿಕಮ್ ಪೋರಸ್ ಅಂದರೆ ತೂತ ಆಗುತ್ತೆ, ವಿಚ್ ಪ್ರೀಡಿಸ್ಪೋಸಸ್ ಇಟ್ ಟು ಫ್ರ್ಯಾಕ್ಚರ್. ಸೊ ಬೋನ್ ಡೆನ್ಸಿಟಿ ಕಡಿಮೆ ಆಗಿ ಫ್ರ್ಯಾಕ್ಚರ್ ಆಗೋ ಚಾನ್ಸಸ್ ಜಾಸ್ತಿ ಆಗುತ್ತೆ. ಇನಿಷಿಯಲಿ ಮೈಕ್ರೋ ಫ್ರ್ಯಾಕ್ಚರ್, ಅದಾದಮೇಲೆ ಮ್ಯಾಕ್ರೋ ಫ್ರ್ಯಾಕ್ಚರ್. ಸೊ ಇಟ್ ಈಸ್ ಅ ಕ್ವಾಂಟಿಟೇಟಿವ್ ಡಿಸೀಸ್. ಬೋನ್ದು ಕ್ವಾಂಟಿಟಿ ಕಡಿಮೆ ಆಗುತ್ತೆ, ಕ್ವಾಲಿಟಿ ಏನೂ ಕಡಿಮೆ ಆಗೋಲ್ಲ. ಯಾಕಂದರೆ ಮಾಸ್ ಟು ಮಿನರಲ್ ರೇಷಿಯೋ ಸೇಮೇ ಇರುತ್ತೆ, ನಾರ್ಮಲ್ಗೂ ಇದಕ್ಕೂ ರೇಷಿಯೋ ಏನು ಚೇಂಜ್ ಆಗೋಲ್ಲ, ಬಟ್ ಕಂಪ್ಲೀಟ್ ಬೋನ್ ಮಾಸ್ ಈಸ್ ರೆಡ್ಯೂಸ್ಡ್. ಸೊ ದ ಬೋನ್ ಡೆನ್ಸಿಟಿ ಆರ್ ಮಾಸ್ ಆರ್ ವಾಲ್ಯೂಮ್ ಡಿಕ್ರೀಸ್, ಬಟ್ ದ ಬೋನ್ ಕ್ವಾಲಿಟಿ is normal. It can be classified into two types. Okay, it may involve entire skeletal body involve ಮಾಡ್ಬೋದು, ಅಥವಾ it can be localized to certain body region. So it is called as localized osteoporosis. Okay, in case of disuse osteoporosis, ಯಾವಾಗ ಹೆಮಿಪ್ಲೇಜಿಯಾ ಆದಾಗ ಇಮ್ಮೊಬೈಲ್ ಆಗಿರ್ತಾರೆ ಪೇಷಂಟು, ಒಂದು ಸೈಡ್ ಫುಲ್ಲು ವರ್ಕೇ ಆಗ್ತಿರಲ್ಲ. ಸೊ ಬೆಡ್ ರಿಡನ್ ಪೇಷಂಟ್ಸಲ್ಲಿ ಕಾಣ್ಬೋದು ಡಿಸ್ಯೂಸ್ ಅಟ್ರೋಫಿ ಆಫ್ ಲಿಂಬ್ ಯಾವುದು. ಯೂಶಲಿ ಬೋನ್ ಡೆನ್ಸಿಟಿ ಆಫ್ ಅಪ್ಪರ್ ಲಿಂಬ್ ವಿಲ್ ಬಿ ಲೋವರ್ ದ್ಯಾನ್ ಲೋವರ್ ಲಿಂಬ್. ಸೊ ಅದೇ ಅಪ್ಪರ್ ಲಿಂಬ್ ಆಸ್ಟಿಯೋಪೋರೋಸಿಸ್ ಇಸ್ ಮೋಸ್ಟ್ ಕಾಮನ್. ಅದರಲ್ಲಿ ಪ್ರಾಕ್ಸಿಮಲ್ ಬೋನ್ಸ್ ಆರ್ ಮೋರ್ ಅಫೆಕ್ಟೆಡ್ ದ್ಯಾನ್ ಡಿಸ್ಟಲ್ ಬೋನ್ಸ್. ಇಫ್ ವಿ ಕಮ್ ಟು osteoporosis that involves entire skeleton, it is called as metabolic bone disease. Okay, it can be of primary or secondary origin. Primary, there is only 3 primary osteoporosis, which is post-menopausal osteoporosis, most important one and most common one. So you should see menopause video and then come to this video. Then senile osteoporosis, which occurs in the old age. Then idiopathic, where the reason is not known. These 3 are the main causes of primary osteoporosis. If we come to secondary osteoporosis, there is a broad classification again. It can be endocrinal, it can be of gastrointestinal cause, it can be due to drugs, it can be due to neoplastic changes or other miscellaneous causes. If we come to endocrinal disorders, hyperparathyroidism. Okay, what it does? Increase PTH causes bone resorption. It increases free calcium level. Even in hypothyroidism or hyperthyroidism, there will be decreased calcitonin. Okay, where parathyroid hormone and calcitonin has opposite action. ಪ್ಯಾರಾಥೈರಾಯ್ಡ್ ಹಾರ್ಮೋನ್ ಹೈಪರ್ ಪ್ಯಾರಾಥೈರಾಯ್ಡ್ ಆಗಿದ್ದರೆ ಕ್ಯಾಲ್ಸಿಟೋನಿನ್ ಕಡಿಮೆ ಆಗಬೇಕು. ಹೈಪೋಗೊನಾಡಿಸಮ್, ಕುಶಿಂಗ್ಸ್ ಡಿಸೀಸ್, ಕುಶಿಂಗ್ ಸಿಂಡ್ರೋಮ್, ಅಡ್ಡಿಸನ್ಸ್ ಡಿಸೀಸ್, ಡಯಾಬಿಟಿಸ್ ಮೆಲಿಟಸ್ type 1. All these endocrinological disorders are associated with secondary osteoporosis. Whereas in gastrointestinal cause, malnutrition ಆಗಿರ್ಬೋದು, due to decreased protein, ಯಾಕಂದರೆ protein is also a main component in the bone, osteocalcin. Okay, then malabsorption, decreased absorption of protein, hepatic insufficiency, vitamin C, decrease in the vitamin C level, which is required for osteoid formation from osteoblast cells. Osteoblast cells form osteoid units that requires vitamin C. So vitamin C deficiency, then vitamin D deficiency for calcium deposition. Okay, these are all the causes for genito-intestinal cause of osteoporosis. Drugs, most important is corticosteroids. Most important cause of iatrogenic osteoporosis is due to usage of corticosteroids, main side effect. Then due to anticoagulants, anticonvulsants, then due to alcohol. In case of neoplasms, the bone neoplasms like multiple myeloma, Benz-Jones proteins are increased, which are very low quality protein. Carcinomatosis or metastasis to bone. Any metastasis to bone decreases its strength. Miscellaneous causes are immobilization, disuse, decreased physical activity, then osteogenesis imperfecta, then anemia. These are all the broad classification of osteoporosis based on their causes. If we come to pathogenesis, in young age, osteoblastic activity will be more than osteoclastic activity. Therefore, there will be increased bone production than resorption, right? There will be peak bone mass, maximum bone mass. By this production, there will be maximum bone mass achieved at young adulthood, approximately around 30 years of age. Young healthy adult will have his maximum bone mass at 30 years of age. After that, osteogenesis, level of osteogenesis will be equal to osteoclastic level. Activity of osteoblast and osteoclast cells will be equal. As the age progresses, again osteoclastic activity overrides osteoblastic activity. What are the functions of osteoclast? Bone resorption. So the bone resorption keep on increasing, bone mass density keep on decreasing. So the bone formation is lower than the resorption. So every year physiologically, normal adults, there will be approximately 0.7% of bone loss. 0.7% of bone is lost in the normal, whereas in post-menopausal female, decades after menopause, so because it is osteoporosis, as we discussed, is a late complication, bone reduction may reach up to 2%. 0.7% LE, 2% LE, 2% bone loss in cortical bone. If you know, bone have long bone, epiphysis, between that is metaphysis, and you have outer cortex cortical bone, then cancellous, web-like cancellous or trabecular bone. 2% of cortical bone per year is lost, and 9% of cancellous or trabecular bone is lost. Therefore, in post-menopausal osteoporosis, trabecular bone or cancellous bone is most affected. Okay. At the end of 30 to 40 years, so at the end of 30 to 40 years of menopause, only 50% of cancellous bone may be remaining, and 35% of cortical bone will be resorbed. So trabecular bone 50% resorb ಹೋಗ್ಬಿಟ್ಟಿರುತ್ತೆ, only remaining 50% is remaining. Okay, what is the cause? Why does this occur? So the main culprit is the estrogen. There will be decreased level of estrogen. What does it cause to bone? Normally, osteogenesis stimulates inflammatory cytokines, which increases the rank ligand. Rank ligand are present on the osteoblast cell, and rank receptors are present on the osteoclast cells. What is that? Inflammatory cytokines stimulates this rank ligand. This rank ligand acts on rank receptors. Normal. But what happened? Estrogen also produces a protective factor called osteoprotectin, OPG, which inhibits the rank ligand to stimulate rank receptor. Therefore, osteoblastic activity will be more than osteoclastic activity. There will be increased bone production. Whereas here, as estrogen level is decreasing, there will be less expression and synthesis of osteoprotectin. There won't be inhibition of rank ligand. So there will be increased activity of rank ligand and rank receptor, which promotes the osteoclast recruitment and therefore promotes the resorption of bone. So here what happens? There will be accelerated bone resorption, which cannot which cannot be compensated. Even the osteoblastic activity is normal. Here the osteoblastic activity is normal, but the resorption is high, so it is called as high turnover form of osteoporosis. There is a turnover with osteoporosis. This mainly affects the cancellous bones of thoracic and lumbar vertebra. Postmenopausal osteoporosis affects thoracic and lumbar vertebra, whereas in senile osteoporosis, ವಯಸ್ಸಾದಾಗ ಏನಾಗುತ್ತೆ, capacity to produce new bones will be decreased by osteoclast normally. So it is called as low turnover form of osteoporosis, where new bone ಆಗದೇ ಇಲ್ಲ due to decreased osteoblastic activity. They may mainly affect the cortical bone in the overall skeletal, where subperiosteal and endosteal resorption is more. ಇಲ್ಲಿ ಪೆರಿಯಾಸ್ಟಿಯಂ ಕೆಳಗಿರೋ ಬೋನು ಮತ್ತು ಎಂಡೋಸ್ಟಿಯಂ ಕೆಳಗಿರೋ ಬೋನ್ ರಿಸಾರ್ಪ್ಷನ್ ಜಾಸ್ತಿ ಇರುತ್ತೆ. ದಿಸ್ ಈಸ್ ಅಬೌಟ್ pathophysiology of postmenopausal and senile osteoporosis. What are all the clinical features? Earliest complaint ಬಂದ್ಬಿಟ್ಟು ಬ್ಯಾಕ್ ಏಕ್ ಅಥವಾ ಬ್ಯಾಕ್ ಪೇನ್ ಡ್ಯೂ ಟು ಮೈಕ್ರೋ ಫ್ರ್ಯಾಕ್ಚರ್ಸ್. ಓಕೆ, ದೆನ್ it leads to macro fracture and fragile fractures. Bone becomes very fragile. Even minimum weightlifting can cause fractures. Most commonly, fracture of spine at the level of thoracic and lumbar vertebra, fracture of neck of femur and hip, Colles fracture. Okay, all these occurs. Here the most common is spine, where the spine starts to bend forward after the fracture, so which is called as kyphosis. As spine fractures and he bends forward, naturally the height of patient keeps on decreasing. These are the clinical manifestations. If we come to investigations, laboratory investigations will almost be normal. There can be slight increase in calcium level in blood, but it is not a diagnostic. X-ray can be done, but it is not the investigation of choice. So what are all the X-ray findings? Codfish or fish mouth vertebra is a classical sign in the X-ray of spine. As vertebra is getting thinned, the nucleus pulposa of intervertebral disc pushes out. So normally it will be like this: vertebra, intervertebral disc, its center contain nucleus pulposa, whereas here vertebra is getting thinned and the nucleus pulposa is pushing outside. Okay, like this it gives a classical codfish or fish mouth appearance. So the vertebra starts to compress around the disc, but this can be evidently seen only if there is 30% of bone loss. We can't wait up to there. Patient 30% bone loss ಆಗಲಿ ಅಂತ ಕಾಯ್ಕೊಂಡು ಕೂರೋಕ್ಕಾಗಲ್ಲ. There should be early diagnosis or screening. So the best method for screening is DEXA scan. What is DEXA scan? It is called as dual energy X-ray absorptiometry. Dual energy X-ray absorptiometry, DEXA scan. Other methods can be quantitative CT scan, but what are the side effects on the radiation exposure with it? That is a side effect, but it is also little expensive. So DEXA is more preferred. Single photon emission absorptiometry. This doesn't give a generalized picture. Localized picture ಮಾತ್ರ ಯೂಸ್ ಮಾಡ್ಬೋದು. So DEXA scan is the best method to get the value of bone mass density. So after we do DEXA scan, we will get a value of x gram per centimeter square. So this is the unit of density, bone mass density. If anybody asks you what is the unit of bone mass density, it is gram per centimeter square. Okay, so you'll get an x value. This value can be compared with the bone mass density of a young healthy adult of same sex and race. Young healthy adult of 30 years of same sex and race, but his age is very younger than the postmenopausal woman. It is called as T scoring. Okay, You can remember T as 30 years. T for 30 years, young adult. Whereas this bone mass density can be compared with a same age postmenopausal lady of same race. But there will be decreased bone mass density. They can be pathological. You can't compare decreased bone mass density. You should compare it with healthy. So T score is more preferred than Z score. Okay. This T score will always be negative, as the bone mineral density of old woman will always be less than young woman. So it is compared with young woman whose bone mass density will be less. It is how much less than the young woman that matters. Okay. Then this Z score can be used to rule out the other causes as it is taking in the same age. ಸೇಮ್ ಏಜಲ್ಲಿ ಎಷ್ಟಾಗಿರ್ಬೇಕು, ಎರಡರಲ್ಲೂ ಕಡಿಮೆ ಡಿಕ್ರೀಸ್ ಆಗಿರ್ಬೇಕು. ಈಗ ನಾರ್ಮಲ್ ವುಮನಲ್ಲಿ ಕಡಿಮೆ ಡಿಕ್ರೀಸ್ ಆಗಿದ್ದರೆ, ಈ ಬೋನ್ ಮಾಸ್ ಡೆನ್ಸಿಟಿನ ಈಗ ತೊಗೊಂಡಿರೋ ಪೇಷಂಟಲ್ಲಿ ಕಡಿಮೆ ಆಗಿದ್ದರೆ ಇಟ್ ಈಸ್ ನಾರ್ಮಲ್. ಬಟ್ ಇಟ್ ಈಸ್ ಡಿಕ್ರೀಸ್ ಮೋರ್ ದ್ಯಾನ್ ದಟ್ ಅಂದರೆ ದ ಕಾಸ್ ಇಸ್ ಅದರ್ ದ್ಯಾನ್ ನಾರ್ಮಲ್ ಆರ್ ಆಸ್ಟಿಯೋಪೋರೋಸಿಸ್, ಆ ಥರ ರೂಲ್ ಔಟ್ ಮಾಡೋಕ್ಕೆ. ಓಕೆ, ಇಫ್ ವಿ ಕಮ್ ಬ್ಯಾಕ್ ಟು ಟಿ ಸ್ಕೋರ್, ಸೊ 0 is the normal value, is the mean value considering bone mass density of a young 30-year female. Okay, 0 to -1, if there is the decrease in 0 to 1 values of standard deviation, it is normal. This classification is given by WHO. Remember this WHO classification of osteoporosis. 0 to -1 is normal. If the bone mass density is less than -1 to -2.5 standard deviation, it is called as osteopenia. Okay, bone weakness. Penia is weakness. If it is beyond -2.5 and below, it is called as osteoporosis. Okay, if the bone mass density is less than -2.5, beyond -2.5, with an evident macro fracture with the patient, clinical manifestation of macro fracture, it is called as severe osteoporosis. So this is a WHO classification: 1, 2, 3, 4. Normal, osteopenia, osteoporosis, severe osteoporosis. Based on this osteoporosis screening, osteoporosis screening is done by National Osteoporosis Foundation. If the female is of age 65 and above, because it is a late complication of postmenopausal, it can occur after 60 years. If a female is menopausal, is at menopausal age and with the risk factor of osteoporosis, that is malnutrition, any other risk factors. Okay, if she is a postmenopausal woman less than 65, still with risk factor, you should screen for it. In case of male, osteoporosis occur in the later age than female, so you should check for 70 years and above, 50 to 69 years with the risk factors. If you break any bone after 50 years, if any patient breaks the bone after 50 years, they should be screened for osteoporosis. This is about the investigation. If you come to medical management, if you come to treatment, it is of mainly medical management. If there is deformity can be corrected by tailor brace, vertebroplasty, balloon kyphoplasty, locking plates. Locking plates will be like this. Balloon kyphoplasty, where they'll inject inside the bone and dilate the balloon in the vertebral disc to create space, then inject a cement. Okay, tailor brace method. Vertebroplasty is injecting the cement without ballooning. So these are the deformity correction. Before that, if we come to medical management, 3 types of drugs can be given. Drug that decreases bone resorption, that decreases osteoclastic activity, or drug that increases bone formation, it increases osteoblastic activity, or drug that does both the activity. What are all those? Bisphosphonates, denosumab, calcitonin, selective estrogen receptor modulators or HRT, that comes under drugs that decreases bone resorption. Okay, drugs that increases bone formation are recombinant PTH, PTH-RH, anti-sclerostin antibody, stromycin. Among this, bisphosphonates are of most important drugs used in the osteoporosis. If we see, there are three generations of bisphosphonate: first generation, second generation, third generation. In first generation we have etindronate, clodronate. Second generation we have alendronate, pamidronate. In third generation we have risindronate, zolendronate. Commonly alendronate oral and zolendronate IV is most commonly used. Okay, this is based on the potency. Lowest potency are not used. First generation drugs are not used. Second generation are of 100 times more potent than first generation, and third generation are of 1000 times more potent than the first generation. And here alendronate and risindronate are of oral drugs. Pamidronate and zolendronate are intravenous drugs. Okay, mechanism of action. First generation, the mechanism of action is formation of abnormal ATP which can't be utilized by maturing osteoclast cell. So there will be immature osteoclasts and there will be apoptosis of osteoclasts. Whereas second and third generation mechanism of action is different, where they will inhibit farnesyl propyl synthase that inhibit mevalonate pathway of cholesterol synthesis. This induces apoptosis of osteoclast. Uses. What are all the uses? It is a drug of choice in all osteoporosis. Bisphosphonates is drug of choice in all type of osteoporosis. Oral is more preferred than intravenous. Oral is given for 5 to 10 years, once a day or once a week dose. IV is given for 3 to 6 years, once a year dose, because it is highly potent. Okay. It is also drug of choice for hypercalcemia in malignancy due to metastasis of osteoclastic secondaries. If the osteoclast is metastasized to any other bone, there can be hypercalcemia due to that malignancy. Again, bisphosphonates is drug of choice. It is also drug of choice for Paget's disease of bone. If we see pharmacokinetics of this drug, they have poor absorption. So it is preferred to give in empty stomach. First advice. Side effect: it causes esophagitis, severe gastritis, it may lead to ulcer. So precautions. Second advice: take the tablet with full glass of water and do not consume anything 30 minutes after that. Should give an empty stomach with full glass of water, and he should not consume anything 30 minutes after that. He should walk upright more than sitting erect for 30 minutes, because it may lead to aspiration or regurgitation of acid. Okay. Next, there will be increased osteoclastic activity. It can lead to severe acute osteonecrosis. Okay. In long term, there can be atypical fracture at subtrochanteric region. It may lead to maximum hypocalcemia, can occur. Zolendronate can cause renal failure. Okay. Next, if you come to denosumab, it is a monoclonal antibody against the rank ligand. You know the mechanism of action. It is used subcutaneously in giant cell tumor, metastasis, multiple myeloma, postmenopausal osteoporosis, Calcitonin can be used. Next, raloxifene can be used, but side effects is heart flashes and venous thromboembolism. Next, recombinant PTH is called as teriparatide, and PTRHH is called abolaparatide. You can see para in both the names: teriparatide, abolaparatide, and they are tides, peptides. They can't be given orally. So maximum duration that can be given is 2 years. There will be increased risk of osteosarcoma. Okay, as it resembles parathyroid, there will be increased osteoblastic activity. There can be increased risk of osteosarcoma, contraindicated in Paget's disease, because Paget's disease itself is a risk factor for osteosarcoma. Okay. Next, anti-sclerostin antibody. What does this sclerostin do? This sclerostin normally inhibit osteoblast and stimulate osteoclast. Okay, this monoclonal antibody inhibits osteosclerostin. Exactly opposite what we needed. So the monoclonal antibody against this is romosumab. So ROMO is romosumab. Next, strontium granulate, which is rarely used, has dual action. It stimulates osteoblast and inhibits osteoclast, what we needed, but it is less commonly used due to its side effect, venous thromboembolism. Other drugs like calcium mimetics can be used, like sinacalcet, calcitide, which is mostly used in hyperparathyroidism. Next, tibolone. Tibolone is a steroid. Which have estrogen plus progesterone plus androgen effect on bone and uterus libido. Okay, then I have mentioned you about the deformity correction, about vertebroplasty, balloon kyphoplasty, locking plate. Okay, recommendation: there should be some nutritional advices. So the daily required calcium supplement should be 800 to 1200 milligram per day, approximately 1.5 mg, 1.5 grams of calcium per day can consume milk. Then vitamin D 400 to 800 international unit, vitamin K 200 to 400 international unit. This is about osteoporosis. Thank you.